I will be presenting an intriguing case that entails the management of a novel AAA in a patient who had previously undergone successful aneurysmectomy for infrarenal AAA. I will be mainly focusing on the common practice of keeping an excessive aortic neck during open AAA repair, which poses a potential risk for a de novo AAA development, and therefore it is good to be avoided. I have nothing to disclose. It is known that the development of an aortic aneurysm is a complex and multifactorial process that may involve an imbalance between the synthesis and degradation of elastin and collagen, together with autoimmune, inflammatory, and hemodynamic responses. Male gender, family history of AAA, smoking, and aging are compromising factors for the development of a AAA, while diabetes seems to be a protective factor. All these factors may continue to operate in the aortic wall regardless of the type of treatment and can cause dilation and elongation of the aortic neck, sometimes extending to the more proximal segment. These findings have been widely analyzed after EVAR, but poorly studied after open repair, which is considered as a more durable procedure. Indeed, the late occurrence of a new dilation in the proximal aorta represents a challenge for subsequent repair and justifies therefore further investigations. In our case, a 79-year-old male patient presented at our outpatient clinic with a novel AAA encompassing the orifice of the left renal artery, as seen in this CTA scan. He had undergone an aneurysmectomy of an infrarenal AAA 13 years ago at a different vascular center, the proximal anastomosis then lying below the orifice of the left renal artery, which was a low orifice, with a superior aortic wall diameter within normal values. DSA findings were same with CTA findings. Left renal artery origin was within the AAA sac, but it was still potent. The right renal artery was found without significant stenosis. After a meticulous cardiopulmonary workup, the patient was considered fit for open surgery. His preoperative creatinine level was 0.7 mg per deciliter. Under general anesthesia and traditional infrarenal clamping, we used a straight 18 mm polyester graft with a 6 mm ePTFE side branch pre-attached to it. After completing the proximal anastomosis, the left kidney was reperfused with an end-to-end anastomosis of the side branch to the left renal artery. The operation was concluded by a distal end-to-end anastomosis of the new to the old polyester graft. The patient was transferred to the ward. No ICU was needed. There were no peri-procedural or postoperative complications. The patient's renal function remains unaffected, and the patient was discharged from the hospital on the 6th postoperative day. He remains in good health after a 1-year follow-up period. A review of current literature shows that the fate of proximal aortic neck after open AAA repair is mainly determined by neck dilatation and elongation. Diameter increase of 0.48 up to 1 mm per year is described with a mean follow-up of patients for 42 months. Dilatation over 5 mm and elongation over 10 mm is also seen in a significant percentage of patients, while the formation of false aneurysm, novel AAAs or TAAs and TAAAs is described due to disease progression and technical issues. Here are the main studies about postoperative aortic neck dilatation, about patients with the formation of TAAs and TAAAs after previous open AAA repair, and recurrent proximal aneurysm formation after any AAA repair. Continuing aortic neck dilatation occurs in up to 43% of patients after open repair. False aneurysm formation is seen in 1.3 up to 3% during long-term follow-ups. In EVAR, neck dilatation has been reported in up to 28% of patients at 2 years and in 59% of patients at 4 years, leading to further adverse events due to endoleak formation. A recent study shows no difference between open and EVAR repairs as proximal aortic neck progression is concerned. As a conclusion, a residual neck of the infrarenal aorta after aneurysmectomy for AAA is a quite common practice for most vascular surgeons, especially trainees, but it poses a potential risk for a de novo AAA development and therefore is good to be avoided. Thank you.